Welcome, everyone. We're going to let people take a few minutes to log in. If you're looking for the first cohort of SAMHSA's Clinical High Risk for Psychosis Grant Program webinar, you are in the right place. And we'll just take a second or two to let everyone go ahead and get enrolled here. All right, well, good morning or good afternoon, everyone, depending on your time zone. We'll still have a few people, it looks like, logging in, but we'll go through this a little bit slowly and give everyone a chance to get on before we get to the actual important parts. So hi, everyone. I'm Abram Rosenblatt. I'm Vice President here at WestStat, and I'm actually the Principal Investigators of the ESMI TTA Center. It's great to at least virtually have all of you joining us. We appreciate you taking the time to spend some time with us this morning or this afternoon, depending on your time zone again. So our presentation today is on the findings from the first cohort for clinical high risk and psychosis. I have a disclaimer for all of you. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Okay, now that we're done with that part, we can go on to a few little housekeeping notes. We are recording this presentation. During the presentation, at any time, you can submit questions and feedback in the chat. And I can see that many of you are saying hello through the chat. That's terrific. Please feel free to do that. And then you will receive the presentation slides via email after the presentation, and also the recording will let you know when that's available, but that will be available at a somewhat later date. I can see again from the chat, everyone's from all over the country. It's great to have you all here. We can go to the next slide. So we are in the opening remarks stage. That's what we're doing now. And then we're going to have overview of findings from the first cohort of SAMHSA's Clinical High Risk for Psychosis Grant Program. We're very excited to share this with all of you. We'll have a panel discussion and then a question and answer session, and then a few little closing housekeeping remarks for all of you. Next slide, please. Okay. So our first presenter is John Cosgrove. John is a Principal Research Associate here at WestStat in the Behavioral Health and Health Policy practice. We're really fortunate to have worked with John on our Early Psychosis Intervention Network National Data Coordinating Center, which is funded by NIMH, where he's done a lot of our harmonization work. He's also worked on our SAMHSA Center for Financing and Reform and Innovation contract for Early Serious Mental Illness Training and TA Center as well, as you can see here. And he's done some work as well for ACF. John's got a terrific background in child welfare and public behavioral health and juvenile and criminal justice systems. He's got his PhD in 2020 from the University of Maryland School of Social Work. And we're just delighted to have John joining us today. So I'll get out of the way. And John, if you'd like to get started, we're ready to roll.
Yeah, thank you, Abram, and thanks everyone for being here with us today. My name is John Cosgrove, and like Abram said, I'm a Principal Research Associate with WestStat, and I've had the pleasure of working with our panelists, Jason Schiffman and Nick Breitbord, along with some of my WestStat colleagues and our SAMHSA partners on a study looking at outcomes for clients served by SAMHSA's Clinical High Risk for Psychosis grantee programs. And so today I'm going to be presenting what we found. So the three key learning objectives for this presentation are to gain knowledge of the signs of being at clinical high risk for psychosis and the implications of developing psychosis, to learn about the Clinical High Risk for Psychosis grant program and how its interventions address the needs of individuals at clinical high risk, and to become familiar with the findings from the Clinical High Risk grant program and how clients have benefited. So next slide, please. Thanks. So to understand what it means to be at clinical high risk for psychosis, it first helps to understand really what we mean by psychosis. So psychosis is a mental state that's characterized by symptoms like delusions, hallucinations, disorganized thoughts, apathy, social withdrawal, and lack of emotional expression. So delusions, hallucinations, and disorganized thoughts are what are considered positive symptoms of psychosis. Not positive meaning good, but just that they're symptoms that kind of present as more active behaviors or thoughts. Whereas negative symptoms like apathy, withdrawal, and lack of expression or affect are kind of more passive symptoms. And typically, those positive symptoms appear first when experiencing psychosis, and then over time, if not treated, those negative symptoms develop. And so when we say psychotic illness here, we're referring specifically to serious mental illnesses like schizophrenia and bipolar disorder with psychotic features, and not psychosis that's due to other causes, such as substance use, traumatic brain injury, and dementia. So these psychotic illnesses typically emerge in late teens or early 20s and can disrupt development during this age of transition to adulthood. These illnesses affect an estimated 1 to 3% of the population, and they're associated with decreases in functioning, such as work, school, and relationships, health comorbidities, such as increased risk of cardiometabolic conditions, premature mortality, including increased risk for suicide, along with significant economic costs, recently estimated to be at around $343 billion per year in the US. So, next slide, please. So, despite the severity and significant social and economic costs of psychosis, recovery is very much possible with treatment that can help individuals with psychosis lead productive and meaningful lives. And the timeliness of this treatment can be a pretty important factor in helping to improve symptoms, restore functioning, and quality of life, with some extensive research showing that minimizing the duration of psychosis or minimizing the duration of untreated psychosis, sorry, can improve the client's response to treatment and lead to better outcomes in recovery. And so, with this emphasis on early intervention, has come an increased focus on identifying early indicators of psychosis risk and the discovery that some symptoms can actually emerge prior to experiencing a first episode of psychosis. And so, this gets us to what we mean by clinical high risk for psychosis. Next slide, please. Thanks. So clinical high risk for psychosis briefly can be understood as exhibiting noticeable changes in perception, thinking, and functioning, typically preceding a first episode of psychosis. There are kind of three key symptoms of clinical high risk. So that would be attenuated psychotic symptoms, which are positive symptoms that do not meet full criteria for psychotic disorders, such as hearing faint noises or seeing fleeting shadows. So during a psychotic episode, an individual might experience hallucinations like seeing someone who's not there or hearing voices telling them to do things. And so by contrast, hearing faint noises or seeing fleeting shadows are also hallucinations, but just less severe. And so that would be an example of an attenuated symptom of psychosis. Another clinical high-risk symptom is a brief psychotic episode. So these are symptoms of psychosis for a short duration that remit spontaneously. And so these symptoms might meet the intensity or severity of psychosis, but they're kind of not pervasive enough to meet criteria of a full psychotic disorder. And then lastly, trait vulnerability and functional decline. So this encompasses both having a predisposition to a psychotic disorder, such as biological or environmental factors like family history of psychosis, and a decline in daily life functioning, such as performance at work or school. And so having both this predisposition to psychosis and decline in functioning kind of required to have the trait vulnerability and functioning decline symptom for clinical high risk. And so these are kind of the three key indicators of being at clinical high risk for psychosis. Next slide, please. Okay, so most individuals, around 80% who experience psychosis, first exhibit some of these clinical high-risk symptoms, which is really significant for early detection and intervention. Although it's also important to note that many people who exhibit these clinical high-risk symptoms never actually develop psychosis. So looking at this chart here that shows rates of transition to psychosis over time, transitioning to psychosis is most likely to occur during the first year after clinical high-risk symptoms appear, with around 15% developing psychosis within this first year. And then we see slight increases in year 2 and 3, from 15% to 19% in year 2 and 19 to 25% at year 3. And then after 3 years, it really kind of flattens off, and the risk of transitioning to psychosis doesn't increase much more. So next slide, please. Thanks. And so going back to the importance of early intervention, it's been shown that intervention during a clinical high-risk phase can be beneficial, with some studies showing that interventions like psychotherapy and pharmacology can have positive effects, such as improving clinical high-risk symptoms and reducing risk of transitioning to a first episode of psychosis. Next slide, please. Okay, so far I've given a pretty high-level overview of clinical high risk for psychosis. There is a prior webinar from this webinar series presented by our panelist Jason Schiffman and some of his colleagues that provides a deeper dive into clinical high risk for psychosis. This webinar is available to watch online through the SAMHSA ESMI Training and Technical Assistance website, and it's really informative. So if you haven't checked that out, I definitely recommend checking that out on their website. Next slide, please. Okay, so with the promising evidence for intervention during the clinical high-risk phase, SAMHSA in 2018 launched the Community Programs for Outreach and Intervention with Youth and Young Adults at Clinical High Risk for Psychosis grant program, also known as the CHR-P program, or CHIRP program is sometimes referred to. And the goals of this program are to identify individuals at risk for psychosis and provide them with evidence-based interventions to help improve functioning, resume age-appropriate activities, minimize symptoms, and delay or prevent psychosis. So next slide, please. Okay, so SAMHSA funded an initial cohort of 21 grantees. They were funded to implement clinical high risk for psychosis programs from 2018 to 2022. And these grantees were public entities, so either a state government or territory, a subdivision of a state, such as a county or city government, or a tribe or a tribal organization. Next slide. So this map shows the locations of the CHIRP grantee programs in the US. And so we can see there are 21 programs located across 18 different states and covering many different regions of the country. Next. So all CHIRP grantee programs provided a stepped care treatment model. This stepped care approach provides the least intensive treatments first, and then graduates on to higher intensity treatments, but only as needed. And so the lower intensity treatments are non-psychosis specifics, for example, stress management and coping skills. And then higher intensity treatments are psychosis specific, such as antipsychotic medications, and come with greater risk of side effects. And so the goal is really to provide the least intensive treatments needed for a successful treatment response. The treatment plans are based on shared decision-making between the client and clinician, and this is supported by ongoing assessment of client symptoms and functioning to monitor progress on treatment goals. So typically, the initial treatment plan is based on an assessment conducted at intake, and then the client is assessed recurrently throughout treatment to determine how they're responding to that treatment plan or whether the treatment plan needs to be modified accordingly. And so all grantees promoted this stepped care approach to treatment planning with clients, although ultimately it was the client's decision on which interventions they received. And on to the next slide, please. Thanks. So there were certain interventions that grantees were required to provide to meet the individual's needs at clinical high risk. And so these interventions included evidence-based screening, assessment, and diagnosis. And so some examples of grantee sites, how they implemented these tools included the structured interviews for psychosis risk syndromes, or SIPs, and the 2-item screen for hallucinations and delusions. And so these screening and assessment tools just help to identify clients at clinical high risk for the program and monitor their treatment goals to inform the treatment plans over time. Another required intervention was psychoeducation, and so some grantee site examples include psychoeducation for families at risk for psychosis and family-centered psychoeducation. These interventions help individuals and their family members kind of better understand their conditions and symptoms. Um, Another required intervention would be substance misuse risk reduction strategies. So examples would include motivational interviewing or referring the client out to substance misuse treatment providers externally. And these interventions were for individuals that were presenting with co-occurring substance misuse disorders or risk for substance misuse. And then cognitive therapy and behavioral skills training. Some examples of these interventions would include CBT for attenuated psychosis symptoms and social and functional skills training. And these really involved kind of more therapeutic interventions to help improve client symptoms and functioning. Another important and required intervention would be the academic, vocational, peer, and family support services. And these might include peer support services in individual and group formats, supported employment and education services, and multifamily groups. And these interventions are only made to address the decline in functioning, such as occupational and social functioning, often experienced by individuals at clinical high risk. And then lastly, evidence-based pharmacotherapy. These would be targeted medications for comorbid mental health and substance use disorders, for example. Um, these interventions come with the highest risk for side effects, and so they're provided kind of only as needed to make treatment progress. Next slide, please. Okay, and then again, this is just kind of an overview of the step care interventions. Our other panelists, like Brightboard, also presented a webinar for this series, and this one gives a deeper dive into the step care models that CHR-P grantees implemented. And so there's more information about this one on the SAMHSA ESMI TTA website as well, and I think the slides and webinar recording are coming soon, so also recommend checking that one out. Next slide. Okay, and then moving on to the findings from our study. The study is titled Stepped Care Intervention for Pre-Psychosis, Finding from the First Cohort of Clinical High Risk for Psychosis Grantee Programs. The citation is on the screen here, but I'm happy to share that this is no longer under review and is now officially in press with the Journal of Psychiatric Services. And so the publication will hopefully be live within the next couple weeks. Okay, so for this study, we analyzed national outcomes measures or NOMS data. The NOMS assess many different areas of client wellness and recovery. The CHR-P program clients completed the NOMS at program intake and then every 6 months throughout treatment and then at discharge. And so, measuring many different areas of client wellness and recovery. So this includes measures of life functioning, social connectedness, and psychological distress, the use of psychiatric hospitalizations and emergency department visits, as well as experiencing a first episode psychosis. And so these were all outcomes that we examined for this study. Next slide, please. Thanks. So a total of 1,331 clients between the ages of 12 and 25 enrolled in CHR-P programs between September of 2018 and December of 2022. Of them, 1,071 completed a NOMS assessment at intake. Of those, most of them, 864 also completed a NOMS at 6 months, and then 207 completed the NOMS at 12 months. And so we saw kind of a drop off between 6 and 12 months. It's important to note that clients were typically enrolled in the program for an average of 11 months. And so typically they would have discharged between the 6 and 12-month NOMS assessments, which is just why we see that drop off between the 6 and 12-month assessment points. And so we looked at changes in outcomes across these time points. So from intake to 6 months for those who were enrolled and then discharged prior to the 12-month assessment, and then from intake through 12 months for those who completed the NOMS across all 3 time points. And we looked at these as kind of 2 distinct groups, the baseline to 6-month group and the baseline through 12-month group, to see if their changes in outcomes over time differed based on how long they were enrolled in the program. So for example, those that were enrolled in the program longer through 12 months may have had greater treatment needs and perhaps took longer to respond to treatment. And so examining the outcomes for these groups separately allowed us to observe these potential differences in outcome changes. Next slide, please. Okay, so these are just this is just some summary statistics of the participant characteristics. So participants were on average about 17 years old. Just over half of them were female. Close to half were white, and 25% were Hispanic, and about 18% were Black. Um, the most frequent diagnoses were psychosis spectrum disorders, so about 44%. It's also important to note that these were mostly unspecified psychosis, which was kind of typically what was used to indicate clinical high risk in this population. And then the majority of diagnoses were either psychosis spectrum disorders or mood disorders, which are those serious mental illnesses with the most risk for developing psychosis. Next slide, please. Okay, so life functioning is measured by a scale consisting of NOMS items that assess handling daily life, getting along with family and friends, school or work performance, coping with challenges or crises, satisfaction with housing situation, and not being bothered by symptoms. And a higher score on the scale indicated greater functioning. And so we used growth curve models to examine changes over time in life functioning scores and found that among the group that was enrolled from intake to 6 months but didn't reach 12 months, there was a significant increase in functioning at the 6-month assessment. And then the group that was enrolled through 12 months, we saw a similar pattern. So there was a significant increase at 6 months, and that gain was sustained from 6 to 12 months. Next slide, please. Okay, so social connectedness, these were measured from NOMS items that were adapted from the perceived social connectedness scale. So this was kind of a previously established and validated scale assessing being happy with friendships, feeling part of a community, and having people in life who provide support in a crisis, listen to and understand problems, support recovery, and support goals and accomplishments. And on this one, a higher score was associated with greater connectedness. And so kind of saw similar patterns here to life functioning, where we saw the most gains early on at 6 months. And then for those that were in treatment through 12 months, that trend kind of increased, but the 6 to 12-month change didn't reach significance. But so we saw a significant increase from intake to 12 months, and that was sustained at 12 months. Next slide, please. Okay, and then lastly, psychological distress. This was measured from NOMS items adapted from the Kessler Psychological Distress Scale. So this was another kind of previously validated scale. This one assesses feelings of nervousness, restlessness, or fidgeting, depression, worthlessness, and feeling like everything is an effort. And so in this one, a higher score indicated more distress. And we saw a significant decrease from intake to 6 months. And again, this trend continued from 6 months through 12 months. Next slide, please. Okay, so since we found that functioning, social connectedness, and distress all improved over time, we also explored the cross-lagged effects between these outcomes that they had on each other, so to kind of better understand how changes in one outcome might affect another outcome over time. And so starting with social connectedness and functioning, we saw that having higher social connectedness at intake was associated with increased functioning at 6 months. And higher connectedness at 6 months was linked to increased functioning at 12 months. Conversely, functioning was not associated with subsequent connectedness at 6 or 12 months. So this kind of shows that there is a correlation between social connectedness and life functioning, but this correlation isn't bidirectional. It's really kind of social connectedness that's improving functioning and not the other way around. Next slide, please. Okay, so then looking at psychological distress and social connectedness. So a higher distress at intake was associated with reduced connectedness at 6 months, but a higher distress at 6 months was not associated with connectedness at 12 months. So essentially the initial negative effect that distress had on connectedness at 6 months essentially went away by 12 months, suggesting that enrollment in the program may have helped to kind of mitigate the adverse effects of distress on connectedness over time. And then conversely, connectedness was not associated with subsequent distress. And next slide, please. And then we saw a similar pattern with psychological distress and life functioning, where at intake, higher distress was associated with reduced functioning at 6 months, but distress at 6 months was not associated with functioning at 12 months. So again, this adverse effect at 6 months was minimized by 12 months. And then the inverse relationship, we did not find that functioning was associated with distress at subsequent time points. Next slide, please. Okay, so looking at findings with psychiatric hospitalizations and emergency department visits. With hospitalizations, we saw that there were pretty low rates at intake, so 8% for those that were assessed at intake at 6 months, and 6% for those that were assessed through 12 months. We saw decreases at the 6 and 12-month assessment time points, although those reductions did not reach significance. But it is important to note that the rates were very rare at intake, so there wasn't a whole lot of room for improvement to begin with, but at least descriptively, we still saw some reductions at the follow-up time points. And then with emergency department visits, again, fairly low rates at intake, although we did see a significant decrease from intake to 6 months in emergency department visits, and this decrease was sustained through 12 months. Next slide, please. Okay, and then lastly, looking at onset of first episode psychosis. Generally, there was a low occurrence of first episode psychosis throughout duration of the CHR-P program enrollment. So only 4% of the clients experienced a first episode psychosis. Of those that did, this psychosis occurred an average of about 8 months after intake. So looking at this rate relative to how long clients were enrolled in the program, it was less than one incident of first episode psychosis per client per year. So in comparison to what's been previously found in the literature, thinking back to that earlier slide showing that individuals at clinical high risk experience psychosis at a rate of about 15% within the first year and 19% within 2 years. This rate among CHR-P program participants is really considerably lower than what's been found among the CHR-P population generally. Next slide, please. Okay, so to summarize what we found, really promising findings across several important outcomes. So we saw improved life functioning, social connectedness, and psychological distress over time. Most of these improvements occurred early on within the first 6 months of treatment and was sustained for those that remained in treatment longer. And then we also saw that social connectedness promoted better life functioning over time, so suggesting that social connectedness could possibly be a protective factor to focus on in treatment. So for example, through the peer and family support individuals that grantees provided. And then we also saw reductions in emergency department visits and very few hospitalizations. So this is suggesting kind of less reliance on costly and more restrictive treatment settings, but again, also pretty low rates at intake. So that also suggests that programs may be intervening early enough to avoid the need for these higher levels of care. And finally, we saw a pretty low rate of onset of first episode psychosis, far less common than the clinical high-risk population generally. So just generally a really positive finding on a key outcome for this population. And last slide, please. All right, so finally some future directions from this work. So evaluating the CHR-P program's impact with a control or comparison group, so something like a randomized control trial or a rigorous quasi-experimental study. We did see that clients improved across a lot of key outcomes over time, but we can't really determine how much of that is due to the CHR-P interventions themselves. So, for example, with the timing of treatment, may have identified and enrolled clients at a time of kind of elevated need, and so some of the reductions we saw may have just been something that would have occurred over time, regardless of the interventions, but. Despite that, we did see very positive findings pretty consistently across several key outcomes, and so this supports investing in more rigorous study with a control or comparison group to better establish the program effectiveness. Another future direction is examining changes in clinical high-risk symptoms. So, looking at things like attenuated psychosis symptoms and brief intermittent psychosis as outcomes. The program grantees did assess these symptoms to kind of identify participants at clinical high risk, but these assessments were not part of the NOMS data that we analyzed for the study. And so, in addition to some effectiveness studies with control or comparison groups, assessing clinical high risk symptoms as an outcome is another kind of important next step from this research. Another future direction would be assessing the role of each program component in client benefits. So kind of thinking back to that array of different interventions that all program grantees were required to provide and examining whether maybe certain interventions or combinations of interventions promote certain outcomes would kind of help to better understand exactly how these CHIRP programs are benefiting clients. And then lastly, disseminating CHIRP programs to more sites. And this one is already in progress. So SAMHSA has since awarded additional cohorts of grantees to provide CHIRP programs in different locations. And so just continuing to implement and evaluate these step curve models across more sites. And so that wraps up my presentation part of this. So I'll kick it back over to Abram for the panel discussion.
Thank you so much, John. And John's not going anywhere. He's going to stay with us for this panel discussion, but we're also going to be joined by a couple of our terrific colleagues, Dr. Jason Schiffman, who's the professor and director of clinical training at the University of California, Irvine. Dr. Schiffman, I'm sure, is known to many of you. He's a professor at Irvine, as I said. He earned his PhD in clinical psychology from USC. His research focuses on enhancing the identification and treatment of individuals at risk for psychosis, with a real emphasis on diagnostic refinement, psychosocial interventions, stigma reduction, and health equity. He secured a lot of grants, over $20 million in funding, including 4 active NIMH grants, one of which looks at suicide prevention among individuals at clinical high risk for psychosis. He's co-founded 3 university community partnerships that support at-risk individuals and is a nationally recognized consultant to the CHR-P programs across the country. As a member of the ESMI treatment and technical assistance team, we're delighted to have him as part of that team. He contributes to national initiatives aimed at improving early intervention services, and he's one of the very few certified trainers for the Structured Interview for Psychosis Risk Syndromes, or SIPS. Dr. Schiffman's also leading the development of a new PhD program in clinical psychology at UC Irvine. Welcome, Jason. Our second panelist here is Dr. Nicholas Breitbord. Dr. Breitbord is Charles F. Sinsabaugh Professor of Psychiatry, College of Medicine Distinguished Professor and Vice Chair for Community Behavioral Health in the Department of Psychiatry and Behavioral Health at The Ohio State University, where he serves as the Director of EPI Center, the Ohio State University Psychosis Program. He serves as a senior collaborator for the Global Burden of Disease Study and is a former member of the American Psychological Association Task Force on Serious Mental Illness and Severe Emotional Disturbances. To this date, his research has been cited over 100,000 times and has been funded by agencies such as the National Institute of Mental Health, NIMH, and the Substance Abuse and Mental Health Services Administration. Welcome back, Nick. It's great to have you with us again. So we're going to ask that you continue to keep sending in your comments and your questions into either the Q&A and chat. I've already seen we've had some wonderful questions come in. We're going to have a discussion now about all this. But to kind of kick this off, we've got a few questions to get us started. And our first set of questions are around social connectedness. And as you saw in the findings, they suggest that social connectedness is an important protective factor for CHR-P clients. So our first question here is, in what ways have you seen peers and family support clients through their treatment journeys?
Thank you, Abram, and I appreciate the warm introduction. I'm really grateful for that. And it's a really great question, but before I answer, I just want to take a minute to thank John for his leadership, determination, and also his raw intellect on the project that he presented. It was really outstanding. And I also can't help but thank you and the entire WestStat team who has helped this work really come to life. And since I'm on a roll, I want to acknowledge the vision and investment of SAMHSA and their many brilliant, passionate, and really unsung leaders who have believed in the CHIRP revolution. And we would be lost without them. And most importantly, I think I want to thank many of the CHIRP programs who are represented here today, who do all the work to support youth and families at CHR-P. that hard work and that commitment that you have shared is like allowed for the collection of these data that's led to the possibility of generating the wisdom that John shared from this presentation that I think can lead to the possibility of helping countless others in the future. And I think this work is like a perfect example of a variety of different folks from different levels, including families and youth, within a system coming together to create something bigger that none of us could do on our own. So I'm grateful for all of that. And in terms of this specific question, I have seen peers and families be absolutely critical in supporting clients throughout their journeys more times than not. So that support I find shows up in a lot of different ways. Like there's tangible things that come to mind, like helping schedule appointments or offering rides or making sure medications are picked up. And then there's like behind the scenes kind of support, like more invisible stuff, like collaborating with therapists or helping problem solve when challenges come up on the fly, or just adjusting their routine to make treatment, uh, the whole treatment endeavor possible. But maybe like most powerful are the intangible things like offering unconditional love or believing in their loved one when things feel dark or holding on to hope and just sort of being present, being there. That kind of consistent emotional presence can be grounding, like being tethered to something stable when a person might feel adrift. So I guess the best support I see is when peers and families walk alongside their loved one, not in front or behind, but beside them. And I think, and actually, I believe that that's like where the most meaningful healing really, really happens.
Thanks, Jason, and thanks for all your wonderful acknowledgments. Much appreciated. And the second question really draws on interventions. And what interventions have your programs offered that help to develop or draw on clients' social networks to support their treatment process?
All right, so maybe I'll start with my philosophy here first, and this really drives how our teams have approached treatment. It's like it's that a client's social network isn't just a source of information. It's bigger. It's part of a milieu. It's part of everything you do and how you plan. So families, peers, mentors, social support, they, along with the client, are the experts on the client's world. And when we make space for their involvement in a meaningful way, it can really help shape the trajectories of care in very positive ways. So in our programs, we've offered a range of interventions that actively develop those networks. Like we offer thoughtful psychoeducation for loved ones, not just about like diagnoses or symptoms, but about hope and how to stay connected and how to support. We also run anti-stigma campaigns, both in community settings and also sometimes with families themselves. We also conduct like targeted social interventions. For instance, like if a child's being bullied, we'll work with the schools to help reduce that. Or in some cases, on the other side of the equation, helping young people with social skills training. I'll wrap up with this thought with peer and family support being so critical. A big part of one of our signature initiatives is the Youth Nominated Support Teams initiative, and families and natural supports are embedded within that. It's sort of an adjunctive approach to care where we systematically bring in supports that have been identified by the client into the treatment team. So they're brought into the treatment milieu. This is, of course, all at the client's direction, but we're trying to create like a supportive web around the client, one that lifts them up and is completely consistent with the findings that John presented today, whereas social support and usually like natural social supports really makes all the difference in positive outcomes.
Thanks very much, Jason. Really appreciate those responses. We have a couple of more questions from our side, and we're also collecting wonderful questions from all of you. I can see them popping up as we talk, so we'll stay tuned for that. This is on program impact, and obviously more research is needed to assess the impacts and effects of specific program interventions or combinations of them on client outcomes. Can you speak to how you have seen clients uniquely benefit from each intervention that your program provides?
So to add on to Dr. Schiffman's thanks for the vision of SAMHSA on this here. I think one of the things that has jumped out to me most as a benefit of these step-based programs here and the model that SAMHSA encouraged us to think about here was that these were not programs comprised of interventions focused solely on attenuated positive symptoms, but recognized that the challenges that individuals at clinical high risk for psychosis experience include and expand into areas of functioning, both social and role, concerns around substance use, physical health, you name it. And if we look back at the literature on treatments for individuals at clinical high risk prior to these SAMHSA-based programs, they tended to look at just a single intervention with a single target, and the results looked modest at best about maybe what we could do to help people in their recovery journeys here. What we see here from Dr. Cosgrove's presentation, looking at this cohort of programs that were organized and recognized that the services provided needed to be comprehensive to target people's multiple concerns here, but also be flexible enough to know that some people will need maybe more services in one area than another. It doesn't shock me that we see that these work very well and noticeably better, at least in these promising preliminary data, than what we've seen in just single-based interventions here. So when I think about our program here, I can think about people who've come in with a specific concern, and we've had a specific intervention that has helped them, whether it's been someone struggling with depressed mood, where we've been able to offer some form of cognitive behavioral therapy to help address that here, or distress around attenuated positive symptoms here, that we've either been able to help the person normalize or develop coping skills around right here via connection with peers who've experienced similar concerns here. But the special sauce, I don't think we're going to find is one single treatment. It's going to be this combination and flexibility of interventions, and making sure that they're all accessible and available to people in one setting as being the thing that's going to really advance outcomes in this group.
So kind of relatedly, are there other interventions you'd add to this special sauce, other components that you think would enhance CHR-P programs? And if so, how do you think they might benefit clients?
Well, I'll give one anecdote. When we've looked at outcomes in individuals in our program at Ohio State University, one of the things that we found was a predictor of poor outcomes that we were not even thinking of on day one was either were attenuated symptoms of mania right here, that the presence of these early on among individuals at clinical high risk was one of our strongest predictors we found around worse social functioning, role functioning, and symptomatic outcomes down the road right here. So one of the things we've realized is we need to get ahead of these, and we didn't really have a resource that was targeting these right here. So one of our faculty, Dr. Ann Holmes, has recently, and I'd say very thankfully for us, added social rhythms therapy to part of our menu of services that we've offered to folks here, with the idea that we can offer individuals who are struggling with not necessarily full manic symptoms, but struggles with emotion regulation early on right here, access to a treatment that is one of the few that we know is out there, not necessarily been tested in CHR-P specifically, but among individuals in general, with helping to address this concern here. The other thing that we've realized in our program we've had to get better at right here is addressing both cannabis and nicotine use among our groups here. Ohio is one of the states where there's recreational cannabis use that has been put into law, and it has led to, I think, anecdotally, a shift in people's perception of the risk of cannabis early on right here. So while we had services available for people who are struggling with cannabis use disorder, and we have a group for that here that's been helpful, we realized in our early psychoeducation with folks here, we needed to step up a little bit more to provide information about what the risk really is, and how the risk profile and the legality of it are two very different things to consider here as people make the choice.
Thank you so much, Nick. That's really, really interesting, and really appreciate your response. We've got quite a few terrific questions that we're going to begin to go through for our full panel. And also, I'm seeing in the chat, several of you are making really wonderful comments. So I hope you're all monitoring and looking at the chat as well. It's great to try to get as much participation as we can in this kind of webinar setting. So I'm going to begin with some of these questions, and anyone on the panel, of course, feel free to chime in. I thought this one was really interesting because I was wondering the same thing. What do you all make of the comparatively low rates of transition to first episode psychosis? Does this mean that early intervention is working, or are there other factors that you think contribute to this statistic?
Yeah, I mean, I'd say that that points to one of those critical next steps, which is evaluating the effectiveness of this program with a control or comparison group. So just comparing what we found within, within this treated population to the mature population more generally, has limitations. So it could be that some of these programs have targeted a lower risk group of individuals. Or it could also be that they maybe started treating them at a different time point. So remember, the greatest risk of transitioning is within that first year after experiencing symptoms. And so if some of these clients had already experienced clinical high risk for some time before the intervention started treating them, then by definition, they're kind of lower risk to begin with. And so that's kind of my take on that. I don't know if Jason or Nick have other thoughts.
So I think I want to throw something out there that might be somewhat controversial because I'm going to speak beyond the data. Well, I'll ground it in my understanding of the literature and that risk increases when you recruit from populations that are already treatment seeking and or are in clinical need versus sort of general population. Most of the CHR programs are recruiting from people that by definition, are in need. And so I think the risk of conversion for folks from that vantage point who are enrolled in CHR-P programs is relatively high. So I don't have the data to support this other than what I just shared, but I think that there is at least some potential for us to say that these programs are working. They're working as intended. They're working to reduce the transition to psychosis or at least forestall or delay it. Again, I say that hesitantly, but that is the theoretical movement behind all of that, all of what we're doing. And we're recruiting from people that are in need, and we're working with them and supporting them in a variety of different ways. And we're finding that their outcomes are better than people in research that don't have the same luxury of the kinds of supports that are offered to our CHR-P clients. So I think that there is at least some evidence to stake an argument that the work that we're doing here matters and is working as intended.
Yeah, I'll second Dr. Schiffman's conclusion right there here. And piggyback on it a little bit to say that also what's encouraging, I think, about these programs is that the challenges that individuals at clinical high risk face in their recovery are not limited solely to transition to psychosis right here. We see incredibly high rates of other mental health comorbidities, substance use concerns, functional problems, and we are seeing improvements in those areas as well as a fingers crossed, hopefully lower conversion rate as well here too. It's these programs, even among folks who may not have gone on to convert, are still offering a meaningful benefit in terms of their lives and their health in the world right here. And I think, we're hopefully over time going to be better able to unpack all the potency that these really ultra early intervention programs can offer in terms of promoting recovery.
Thanks very much. Again, great question from the audience. There's more here than we'll be able to go through, but we'll try another one that I think is very useful. How did clients get referred or find their way, or how do clients get referred and find their way to these kinds of clinics?
Well, I will say in our program, there are no singular pathways that we can require here. Our program relies and requires a very active engagement group with the community that is designed to provide information to the various stakeholders that may intersect with individuals in this age range right here about what the early signs of psychosis look like, as well as what to do if you see them, and that there is a service available to help. So we spread the word frequently and wide within our community, targeting schools, hospitals, youth groups, even insurance companies who have shown some interest in trying to identify folks early on here, with the idea of maybe helping to get them engaged in care before a psychotic disorder works here. To date, our largest referral has actually been school and university counseling centers. I kind of speculate that's because we're located at a very large university, as opposed to that being sort of the magic path for everyone right here. I imagine everyone will find it'll take some work to understand in your community where the best places are to identify youth in this age group here. And making those connections will be critical to help them get in the door.
I echo a lot of what Nick said, and I think there's no like sort of one path and one size fits all. I will say this, in addition to what Nick is saying, that SAMHSA has been very mindful in encouraging CHR programs to think about being a part of a continuum of care. And that continuum of care recognizes that we are a part of a larger network of care that surrounds us within the community. So things like outreach and education and screening and very like pointed engagement are critical to bringing folks in. So we see things like schools and universities and clinics and foster homes and even insurance, as Nick was saying, and Boys and Girls Club outreach, NAMI, family groups, even public advertising make a difference as we situate ourselves within a continuum of care with our partners that are providing services throughout our local community.
Thanks very much. We have more questions than we'll be able to get to, which is a nice position to be in. We have about 4 more minutes before I do about a 5-minute wrap up at the end. So I'm going to ask one more that I think is also terrific. They're all great questions, but I'll just try to feature this one. What type of natural coping skills are you seeing that are effective for individuals experiencing psychosis to manage their symptoms?
So I'm not sure if this like hits the question right on the head, but there's a variety of different strategies I think that could be useful, especially at the CHR, the clinical high risk phase. In terms of natural resources or resilience factors, one of the things that we like to share is a program called Youth Nominated Support Teams. And in this model, we work with the client to identify supportive adults that are already in their world and bring them more readily into the treatment plan. So that instead of just having like, oh, you can call this person if you're in distress, having that person be enmeshed within the treatment strategies and approaches to care so that we're all on the same path. So it's sort of a natural coping skill. And then I think there's evidence-based support for things like VG Middle's work on exercise, like physical exercise can be helpful, I think, as a internal support, and even things like Michelle Freeman Yakubian and Michelle West's INVEST model that I think has a lot of insights in terms of how to support a person's ability to thrive in their educational or occupational settings. Could be another internal coping skill that could be employed by folks at risk for psychosis.
Yeah, piggybacking on that, we will do a lot of work in our program here around helping folks with building and strengthening their peer network right here. We've taken an approach with pros and cons where we've sort of thought about, sort of 2 pathways to challenges that interfere with people having strong peer networks. One is sort of just a lack of availability to connect with others right here. That it's just it's not available for them to do, and the other is folks who, for one reason or another, are either uncomfortable or are struggling with building up peer relationships with others here. So we've taken this 2-pronged approach here, where to help folks in building their social networks among age-matched peers, if the concern is one of they just don't they for one reason or another don't have opportunities to engage with others, we've established a peer group where they can at least have a place here to spend time with other people their same age right here, and also in sort of a stigma-free environment where they can talk about their mental health concerns. And that's been really nice. And they've actually gone out, and they thought they got in trouble once here because they hung out outside a peer group, and we're like, no, that's great. That was kind of the goal of all of this here. That was a wonderful conversation. But for folks who need some skills, maybe in managing anxiety or learning pragmatic skills, like how do I start a conversation with someone I've never done? We offer a social skills group for that group here. And that sort of pairing has worked well with us, with our folks here, in helping people with either getting access to peers to spend time with, or strengthening those foundational skills to help them get out in the world and do more. And our thought has always been that the more positive peer engagement they're having, the better in terms of a natural support that is helping them cope with just not only their illness, but being a young adult in this world, which can be challenging.
Thank you, Nick. That's a great note, I think, to end on. And again, I want to really sincerely thank our panelists, Drs. Cosgrove, Schiffman, and Brightboard, for the wonderful presentation and also for your thoughtfulness in answering these terrific questions. I'm very sorry to all of you that we can't get to all of them. But I do want to give you just a couple of bits of information to wrap up. And again, thank you to all of the participants here for all of your questions and for your active involvement. It really is helpful for all of us to see what it is that you are interested in learning more about. We really appreciate your feedback on today's webinar. You can do that little QR code thingy you see up there and do it that way, or you can click that tiny URL thing. And you'll see there's a little link that's in the chat for you that you can go to, and we really do appreciate your feedback. It's really important to us and to SAMHSA. If we go to the next slide, please. We do have several webinars coming up for you all that we hope you will be able to attend. There's the role of peer specialists in early serious mental illness programs on July 29th at noon. And you can register by clicking that little register thingy. And then the developmentally informed shared decision making also is available for registration. That's August 12th at noon. And then we're not really ready yet for registration, but do keep on your calendars and look for it, and we'll make sure you all see partnering with crisis services and early serious mental illness programs, September 3rd at noon as well. If we can have our next slide. So here is some important information for all of you about how you can reach SAMHSA if you need to. Again, I want to thank all of you for joining us. These slides will be made available to all of you after the presentation. And if you look through the chat, you'll also see links to the presentations that Dr. Cosgrove mentioned in his talk. And so you can go ahead and take a look at that. And we'll let you all know when a recording of this is available for all of you to look at and share at your leisure. Again, thank you so much, everybody, for spending some time with us. And we look forward to seeing you in future webinars and presentations as well. Thank you very much.